Now, this is a very interesting X-ray, and we are going to decode the underlying valvular disease because in ischemic heart disease, we won't be having this much of a large heart. Now, we know that this is heart. We always compare this with the, uh, we see that these are the inner portion of the ribs, and we always see this distance. And if the heart is more than 50% of this distance, then we call it as cardiomegaly. Now, if you can see, this is pretty large. This is almost 70% of this inter-rib distance. So definitely, cardiomegaly is there. So uh, to come to the diagnosis of what exactly the disease the patient must be having, we need to see few things. For example, the most important thing is apex. So we know that apex beat or apex is the downmost outermost portion of the heart or the precordium where the definite thirst can be filled. So that is apex beat. Now we see that apex beat has to be medial to mid-clavicular line. So it has to be medial to mid-clavicular line. Now when we see, this is the rib and this is the clavicle bone, and this is coming to this shoulder joint. So medial to this is the mid-clavicular line. So ideally the apex beat should have been here, but the apex beat is up to very much down and out, so it is almost here. So this is the portion of apex. So apex is this much down and this much out, means the patient must have volume overload. Without volume overload, the apex cannot go out. So the apex beat, it was supposed to be here, it has moved from here to here. It means that there must be volume overload, or it can also be because of the dilatation post MI. But in MI patients, in congestive heart failure patients, we don't get this much of huge cardiomegaly, though we can definitely see the cardiomegaly. But in this case, we'll be talking about the valvular diseases. So the apex is very much down and out, so volume overload has to be there. So when we think of volume overload, we have few differential diagnoses like VSD has to be there, ventricular septal defect, atrial septal defect has to be there, mitral regurgitation has to be there, and aortic regurgitation has to be there. So VSD, as we know, is very common in around 4 to 5th decades. We very commonly see that, and we see that in male patients. ASD is more common in female patients. In both this scenario, we actually have to be very careful with the murmurs, because with VSD, what we see is we have a hole between a ventricle, that is right ventricle, and the left ventricle. So we can see that uh, a, a pan-systolic murmur around the sternum. We can see that pan-systolic murmur around the sternum, that very commonly justifies ventricular septal defect. If there is right ventricle to left ventricle shunting, then we can see cyanosis in this patient. So we always have to look for clubbing and cyanosis, and we have to see a pan-systolic murmur. In ASD patients, definitely this type of heart can be seen, and where we get very commonly a loud P2 or loud S2 component. The second sound is split. It is split constantly, and we see a loud P2 component or loud S2 component. So in here, the valvular pathology which we very commonly we either have is either MR or AR. So we know that if you just want to see in here, just for the sake of understanding, what we have is LV around here, and what we have is aorta, which goes like this, and we have the RV which will be around this area. So RV is there, LV is here, and this will be a right atrium. So uh, when we are talking about AR, aortic regurgitation, what we very commonly see is the the blood flows from aorta back to again LV. So it goes out of the aorta and it comes back to LV. So LV dilatation is very common, but as we know that we have a mitral wall, we have a mitral wall which, if it is good, if it is competent, if it is well, if there is no mitral wall pathology, then the left atrial appendage or left atria should not be in enlarged state if the patient has aortic regurgitation. So you have to understand this thing again, as I told, that this is LV. This portion here is of left atrial appendage or left atria. So we have a mitral wall here, and we know that the aortic wall is here. So the blood is flowing from aorta. So in aortic regurgitation, the blood will fall down to LV, but if mitral wall is patent, the left atria should not enlarge if mitral wall is good. So AR can commonly cause left ventricular dilatation. It is pretty clear, but it cannot on its own cause left atrial enlargement. And what we are seeing here that not only LV is dilated, LV is so much down and out, but this is all area of the left atrial appendage, and it is pretty large. It has to be in concave shape, but in here it is convex shape. It means the left atria is also enlarged because of the volume or the pressure. So if there has to be a single pathology, we know for sure that here volume is the problem, because pressure will cause concentric hypertrophy and not dilated hypertrophy. So here volume is more, means the chances is very high that the patient has mitral regurgitation. So if the patient has mitral regurgitation, then simply there will be more blood coming to the LV. It will again go to LA. So both these areas will be volume overloaded, so that apex will go down and out, and left atrial appendage will also be in increased size. So as we know, this LA in left atrium, all the pulmonary venules, all the pulmonary veins, they get emptied into LA. So if left atrium is enlarged, if left atrial pressure is high, the pulmonary veins pressure will be high. So it means the pulmonary venules pressures will be high, means the pulmonary capillaries pressure will be high, means when it reflects, these capillaries are formed from pulmonary arterioles, means pulmonary artery. Then there will be pulmonary arterial hypertension. This is how this back pressure causes pulmonary arterial hypertension. So there will be increased stress on the right ventricle, and that will again cause increased pressure on the right atrium. So as we know and as we can see in here, if you want to demarcate, this is the area of right atrium. Up to here will be right ventricle. So this is right ventricle, this is right atrium, and this is all left ventricle, and this portion is of the left atrium. So in here we have mitral wall, and in here we have the aortic wall. So this is the basically this is the aorta, this is aorta. So this is how there is volume overload in LA and LV. That is most probably because of the mitral regurgitation. Because if it would have been of aortic regurgitation, the LA should not have been this much large. So the possibility of this patient having a severe MR and dilated LV because of the severe MR, causing moderate to severe pulmonary arterial hypertension is pretty high. And this patient was admitted. This patient had severe MR, which was diagnosed on echocardiography. This patient had moderate PH, and this patient definitely had a dilated LV, dilated LA, as it is very much evident on this X-ray. So this is all about now, and thanks and like